Dear colleagues, dear friends, welcome to BG Dental Online Academy. We really grateful that you are with us, that you are watching our online masterclasses and following us in our social medias and also here in that online educational platform. This time we will be doing online masterclass that is dedicated to porcelain veneer bonding, and I will be showing you step-by-step clinical procedures of ceramic veneer cementation with isolation and following all these protocols to make a really clear and systematized understanding of the whole clinical procedures. This online webinar will be, as I told you, dedicated to bonding procedures. So because of our environment, because of our cameras that we have, multiple cameras, we have a special format, and you will be able to attend these webinars like you are here with us. You will have almost presence effect because of the special conditions that we tried to implement for our educational online platform. You'll be able to see everything from my microscope, you'll be able to see my hands, you'll be able to see that camera, so 3 different angles and all complete stuff to give best from BG Academy directly to you. Okay, so we had a lot of responses and a lot of requests from your side, guys, to make that type of webinars about veneer bonding, because you know that previously we have several episodes of online masterclasses about veneers preparations. We did technical aspects of veneer preparations. We did some clinical aspects of veneer preparations, like imitating class 3, class 4, class 5 caries defect, and showing step by step how do we prep veneers in that kind of clinical situations. And now it's time for bonding. Okay, so this is our another episode about long and powerful veneer series. So my friends, let's go directly to our program. By the way, the ones who is watching us now for the first time, to be able to see our previous veneer series, veneer online series, you can go to our webpage en.belgrad.com, and you'll be able to find our special folder, which is online education, and you'll be able to see all these online series that are available in records, so you can see everything we have in our internet. Okay, so now let's imitate a real thing, a real clinical situation. We have patient that came with provisional restorations, and now we have to do try-in, and then we have to provide proper bonding procedures to get a really good and long-term result. Okay, once we removed provisional restorations, sometimes it happens, like for example, personally I do spot etching and spot bonding for provisional veneers to stabilize my provisional veneers for long term, like from 1 week to 2 weeks patient can have these provisional restorations from our side. But once I remove these provisionals, sometimes it happens that you may have some small increment of temporary material. Let us assume after you removed temporary veneers, and here where was spot etching and spot bonding, you'll be able to have some small parts of provisional restoration that may influence the fit of your final restoration. To remove this, we use discs like red or orange from 3M, or there is a better solution. You can use carbide multi-bladed burr with a low speed, no water, just to remove it. But sometimes still you may have some small increments that is pretty difficult to be visualized. If you work with microscope, you can see it easily. But if you don't use magnification, sometimes it's problematic to see in real precise thing, in real precise way, these small increments. So there is a small clinical tip. You may take articulator paper, a thin articulator paper, and just move your articulator paper like this from cervical area to incisal edge, and in the area where you have that small particle, it will be really intensive color of your articulator paper. So that will be easier for you to determine and to identify the small increment and small part of provisional veneer, and you can remove it with a multi-bladed burr. Okay, so this is a small tip. And then we go for try-in. Regarding try-in, you can use try-in pastes from your resin cement system. Okay, but if veneer that is made in lab has a perfect surface fit, that means your dental technician used a really thin layer of spacer. The thin layer of spacer means less than 50 microns. That means that color of cement will not influence the final color of restoration. Also, if your ceramic veneer is relatively thick, for example, it's like a 0.4, 0.5, 0.6, 0.7 millimeters, and it is made of non-translucent ceramic, maybe your dental technician used more dentin, or they milled or pressed veneer from more opaque ceramic. In this case, your cement, the color of cement will not influence the final color of the restoration. In this case, you can use even transparent cement to bond your ceramic veneers. But just to be safe, I do recommend to utilize the same color of resin cement as the color of your veneer restoration. You can use a specially designed try-in paste from cement systems, or even you can just take a glycerin, the transparent glycerin gel or gel for sonography, for example, and you can make a try-in of ceramic veneers. Let me just show you how do we make some try-ins and what parts of try-in is important to pay your attention to. Let me just remove this color from articulator paper. Okay, good. So now we will do try-in. In some cases, you even can do try-in with just water. Okay, we put veneers on teeth. In our case, we will put some water underneath. Okay, that will help us not to get this opaque thing. So we put multiple veneers, and during this step of try-in, we are evaluating color and we are evaluating shape. Okay, what is important to really focus on? You have to see that there is no show-out effect. What is show-out effect? The show-out effect is when you put your veneer on the tooth and you can see in the middle of the veneer the projection of the tooth surface, which is more saturated. So literally you may see some brown spot in the center of your veneer, or the yellow spot because of the color of the tooth. In this case, if you have this show-out effect and the surface fit of your veneer is good, don't try to mask this by opaque cement, because that will not help you. That will be a problem then to remove these veneers. So if you have this effect, the only thing is to redo them, okay? To redo them with a dental technician. And another thing that you have to understand is who is right, who is wrong, who made a mistake. For example, if your dental technician guided you as it has to be, he has to guide you before you start the case. Once you discuss with dental technician the initial color of the tooth and the color that you would like to achieve as the final color of the restoration, and then your dental technician guided you in terms of the thickness of ceramics that he has to have to provide that color change, and you prepped not enough, it's your mistake. If you gave your dental technician enough space and you have this show-out effect, this is the mistake from dental lab. But to be able to understand who is right, who is wrong, we can analyze our cast model, okay? Like it is control cast model. You have cast model, control cast model of your prepped teeth. You have silicon index that we are using for prep control, and then you can put this silicon index over the cast model and just evaluate if there is enough space for your dental technician that you discussed before, or it is not. Okay, so this is some tips. How can you make some evaluations. Okay, so once we determine the color, if color is okay, if shape is perfect, everything is fine, we can start to make precise try-in terms of fit. So in this case I will remove all veneers and will just keep one. I will dry surface, and then I would like to check fit of veneer, dry fit of veneer, to be able to understand if everything is correct. Because if you have multiple veneers on teeth, you may have another problem. You may have a problem of tight interproximal contact. So in this case, we would like to avoid multiple problems. We would like to see if fit is okay, if fit is good, fit to the finish lines, and also from palatal side we have to see the same good fit from palatal side. If everything is good, if you are happy with fit, then you can take another veneer, okay, and do the same, just to control if fit of this veneer is okay. The fit of to the finish line from palatal side as well. And then look what I will do. I will take my first veneer, will put here, and if I can see that I cannot fit my veneer because of the tight interproximal contact, I will take out the second one, and now yes, it fits. Now this doesn't fit. Remove this one, it fits. Go one more time, doesn't fit. This, yeah, fits. So see, there is a problem of tight interproximal contact here. There is a problem of tight interproximal contact. So before you will put rubber dam, we can make some adjustments if it is necessary. Like in this case, we can make some adjustments. What kind of adjustments we can make? We can take an articulator paper, really thin one. I like to work with Artifoil 8 microns. Let me just show you here. Artifoil 8 microns, okay? So we can put this Artifoil between teeth that we would like to check our interproximal contacts. It is not always in every single case. Sometimes you may have this tight interproximal contact problem. Okay, so we put veneer 1, we put second veneer. Okay, don't push, just a little bit. Okay, and then you take your articulator paper out, and you will be able to see these tight areas of interproximal zone. So if you have these supra contacts, you can make some adjustments. To make these adjustments, you have to utilize special rubbers for ceramic. Your dental technician may provide you these rubbers like these, and you just make some adjustments. I will skip the adjustments. You will make some adjustments of these tight interproximal contacts with these rubbers. Then you have to polish them, same as your dental technician does with several rubbers to make a really lustre polishing. And then you can go to preparation, or let's say preparing a ceramic surface for adhesive cementation. Let me just remove with the ethanol. Let me remove this excess of these colors on the teeth, because they will be not good during process of cementation here. Okay, so then if everything is fine, you made an adjustment of interproximal contacts, you can prepare ceramic for bonding. And here we have 3 scenarios. The scenario number 1, pre-adhesive preparation of ceramic surface can be done in dental lab. Your dental technician literally can do everything instead of you. He can make etching with hydrofluoric acid, and then he can make silanization of porcelain veneers. And then you can have your ceramic veneer already silanized. You can do this try-in, and then you can bond them. So don't be afraid if your dental technician gave you veneer already silanized, because once surface of veneer is silanized, or let's say the surface of ceramic is silanized, this surface is hydrophobic. This surface does not afraid any contamination. So you can make try-in, then you just disinfect them with ethanol, and then you can bond them easily. So this is the first scenario. The second scenario, you can do it yourself. You can have these veneers in advance, or your dental assistant can do this instead of you. You can have these veneers in advance, I mean before patient comes to clinic, and then you can make these preparations, I mean etching and utilizing sealant. For this you may use a special interesting tool. This is Veneer Me, very interesting thing. You can put your veneers inside, multiple veneers, see, you can edge them, then you can cover it with a special cover, then you can rinse, you can dry, everything is here, okay. So it's easy to be utilized. It's ergonomic tool. It is ergonomic tool. So you can prepare surface of ceramic for bonding in advance by yourself or by dental lab or by your assistant. In scenario number 3, you will do it like we are doing it here. Personally, I prefer to have the second scenario when I have these veneers, and then I or my assistant can prepare them in advance, and then I have my patient and they make try-in, and then I make bonding procedures. Okay. What else? If we will do this scenario like here in the class, we just make try-in before any preparation, and then patient can stay with no provisionals like few minutes, okay, and you will prepare your ceramic for cementation. Now we will do it step by step, just to make every step really clear, very understandable, and repeatable. We have classic, I will use here classic adhesive protocol for ceramic luting. We have to etch ceramic with hydrofluoric acid. This is the rule of classic adhesive protocol. And in this case, we have to understand what type of ceramic we have to bond, and what type of hydrofluoric acid to be utilized. Basically, if you have lithium disilicate ceramics to be bonded, we may use low percent of hydrofluoric acid. Let's say 5%, or it can be 4, 4.6, 4.7. So this is the low percent ceramic etching gel. Like let me show you here. The one that I'm using is from Bisco. It's porcelain etchant, 4%. So this is that we will use for Emax, okay, or for lithium disilicate. If you will etch, or you have to etch, or you use, let's say, feldspathic ceramics, or you use Lee seed ceramic, we can use 9.5% of hydrofluoric acid. Can be porcelain etch from Cercamed, this is Polish product, or can be also from Bisco, can be from Ultradent. There are many similar products that you can find for free, but you have to be aware of mixing them. So 9.5% of hydrofluoric acid will be used for feldspathic veneers or for Lee seed ceramic, okay? Lithium disilicate has to be etched with a low concentration for 20 seconds. Feldspathic ceramic and Lee seed ceramic has to be etched for 60 seconds with this high concentration of hydrofluoric acid, which is 9.5, okay? We'll do it right now, but before we will do this procedure, let me show you one of the options. How can you prepare your veneer to be holded during process of treatment, okay? Let me just put my veneer here in eye of my phantom. We're not doing this in the patient eye definitely, but just here to show you through the microscope the process. Yes, like this. Okay, so we will prepare this veneer to be easily manipulated during the process of cementation. You can use a special holder from, for example, Optra stick from Ivoclar, or similar product from Shofu, or you can just do one thing that I will show you right now. We will use just flowable, the cheap flowable composite. You just make some drop of the flow here. Okay, you put micro brush, you light cure, okay, and you have really simple and really cheap and really efficient holder for your veneer. Okay, just for reinforcement. Then light cure again. So this is one of the plenty options. Or you can do nothing. You just put your veneers in Veneer Me and you will prepare them with a hydrofluoric acid, and you will silanize them, and that's it. And then you will use your fingers to put your veneers into the patient mouth. Okay, so done. Okay, we have this holder. It's done. It can be prepared by your assistant, not by yourself, so you can use your time more efficiently. Okay, nice. So now, after this, we will do a process of etching and also all the steps to prepare surface of ceramic for bonding. So before you will etch ceramic veneer or crown or overlay, doesn't matter, with hydrofluoric acid, you have to check, really important thing, you have to check if there is no glaze here on peripheral part of ceramic. Okay, if there will be any glaze in that area that I'm showing you, you cannot etch them. Actually, you will etch, but they will be not efficient. The etching will be not efficient in this area, and as you may understand, there will be not proper bonding there. What you can get is the final. You may get a discoloration. There will be a black or brown line between veneer and the tooth in an area of veneer and tooth interface, which is not good. And if your fit of veneer was good and you have this brown line, so it says that you have problems with this glazing. So you have to be really aware of glazing, okay? And you have to see if there is no glaze. If there is glaze, what you have to do? In this case, you may take red diamond in low speed, no water, with a very stabilized burr in a handpiece. You have to remove glaze from internal veneer surface, and only after that you can do etching with hydrofluoric acid. Okay, so let me do etching with hydrofluoric acid one more time. I'm not doing this in my patient face, as you may understand. It's just because of the phantom, and I have rinse out. We will do it outside somewhere. So I will put some hydrofluoric acid here. Okay, it's too much. Wow. Okay, let's put some hydrofluoric acid, and then what is very important also is to move your hydrofluoric acid. See, exactly, I'm showing you with a high magnification. I'm moving hydrofluoric acid on periphery. This is extremely important part, to move it to peripheral area of your veneer. Okay, this is extremely important, as I told you, because you have to etch and you have to prepare this area for bonding process precisely. Okay, then after 20 seconds we will rinse everything. We'll rinse. We have to rinse it very, 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 very precisely. A lot rinsing, a lot of. Okay, good. Then you will dry. And then sometimes if you will over etch ceramic surface, you may get some dusty interface, which is salt. There are really like a white powder or something on the ceramic surface, which is salt, and you have to remove the salt. Otherwise, your process of salinization will be not efficient. Okay. So how do we remove salts? If your dental technician makes etching, he can use steamer. If you do etching here in a clinical conditions and you don't have steamer, you can, after etching of veneer surface with a hydrofluoric acid, you can put your veneer into ultrasonic bath with distilled water or with ethanol for 5 minutes. Or there is another option. You can just take phosphoric acid, the one that you are using for preparation of tooth surface. Okay, we use phosphoric acid. With microbrush, we spread the phosphoric acid all over the surface, but in this case we have to make some activation. So with a microbrush, within 30 seconds, we will make some activation, massage. Okay, so you have to do this 30 seconds. After this, we will rinse and dry, and then we're ready for silanization. Okay, to put some sealant. So we will rinse now. Okay, we will dry. And now we have to put sealant. This is important thing. Once you etch your ceramics with hydrofluoric acid, or your dental technician does, or your assistant, doesn't matter. Once it's etched, the surface of ceramic after etching becomes very sensitive and reactive. It's hydrophilic, and everything that will come to the surface will contaminate it. And these poros that were created by etching will be contaminated with any contaminants. So you have to provide silanization immediately after you etch ceramic system. So now, after etching with hydrofluoric acid, after removing all of the salts with phosphoric acid or with ultrasonic bath, whatever, we put sealant. What type of sealant to use? We have several types and several groups of sealants that are available on the market. The classic one is two-bottle system, like this. This is what we will use. Let me show you here on that camera, microscope camera. The two-bottle system, the one is from Bisco B sealant, group A, bottle B, and then you just have two drops to mix and you will have fresh sealant. Or you can use a one-bottle system, pre-hydrolyzed sealant, for example, the one that people use a lot from Ivoclar, Monobond, or from Ultradent, or from 3M. All of them, they work perfectly. But you have to understand one thing. If you do a lot of ceramic restorations, daily or weekly, which means you use a lot of sealant, you can use any sealant you want. But if you don't do a lot of ceramic restorations, it's better to utilize two-bottle system, because with two-bottle system you will have always fresh sealant. With one-bottle system, which is pre-hydrolyzed sealant, after 5 or 6 months, there will be a chemical reaction within this bottle, and you may lose some efficiency of your sealant. So if you don't do a lot of ceramic restorations, better to use two-bottle system. If you do a lot, one-bottle system is enough. There is one, let's say, new product from Ivoclar on the market, which is Monobond Etch and Prime. This product is it can be used without pre-etching of ceramic surface with hydrofluoric acid. So you skip hydrofluoric acid etching, then you go straight for Monobond Etch and Prime. But from my personal experience, I don't have any clinical experience with this product, so I cannot give you any feedback. I still prefer to use classic sealants and classic protocol, because this classic protocol works more than 20 or 30 years. Okay, so now we will prepare our sealant for silanization. I will take, we have to switch to this camera, okay, because I will use palette here. Okay, this palette. So I will just take the sealant from bottle A, 1 drop. Okay, the sealant from bottle B. Good. And then we will just take a micro brush and mix sealant for just 10 seconds. Okay, and it is fresh now. It's ready to be utilized. It's ready to be utilized. Okay, and we will just, let me switch to the microscope camera, because this is also important to show you the thickness of the layer that we use with sealant. So this is the surface after etching and removal of the salts. Then I take sealant, and you have to use only one thin layer of sealant, not multiple coats, just one thin layer. Okay, one really thin layer. Done. That's it. Okay, and then you can put your veneer anywhere you want. You can put it on your table or anywhere you want. This sealant, the classic one that we are using, is not light curable, so you are not afraid of pre-polymerization because of the light. So you can just put your veneer on the table and sealant will work in this time, evaporate, and that will be a really good sealanization. And in the meanwhile, you can do an isolation for patient's teeth with a rubber dam for proper adhesive protocol. Okay, and while you are doing your isolation process, the sealanization process will be completed, which is really good. Okay, so now what I will do rubber dam isolation. I personally do prefer to cement my veneers with rubber dam, because when I have rubber dam I can control process. If I don't use rubber dam, process controls me. You understand what I mean? When you have some bleeding or saliva or breathing of patient. So you have to be really in rush when you make a cementation, but we have to understand one of the most frequent failure reason of ceramic veneers is debonding. Okay, one of the most frequent reason of failure is debonding. And when you are not using proper adhesive protocol for tooth surface, for ceramic surface, and also to prepare environment, you are compromising your adhesive protocol. So rubber dam is one of the, from my opinion, rubber dam is one of the most important step to complete bonding protocol. I'm not trying to say that if without rubber dam you cannot bond veneers. You can, because I know a lot of people that are not using rubber dam for cementing of veneers, and they have pretty good cases and successful cases. I cannot do this. Once you know how to work with rubber dam, you will love to work with rubber dam, because it is really ergonomic and you can control the process of treatment in a really fast way. If you are really interested in rubber dam isolations in let's say in details, if you'd like to enhance your level in rubber damology, I can refer you to our online masterclass that you may find in our webpage en.belgrad.com in online education platform. Rubber damology, 1.5 hours with our rubber dam, step by step, same as here, so you'll be able to see all these details. I will just do the isolation, and then I will show you some tips related to rubber dam isolation and cementation process. For example, to make these perforations, let me show you in the microscope camera also. I mean preparations for perforations for teeth. We may use several methods. One of the methods is just to use template, or you can put your rubber dam on the tooth surface and make customized marks. Your assistant makes customized marks, then you just perforate them. Or there is a good thing, once you have model, okay, here from the microscope, let's see, this is the model where veneers were made. You have this model. So what you can do, you just put rubber dam over this model, you make some light stretching, okay, just light stretching here, and then your assistant will mark these tips of teeth, and then you perforate, and you will have customized rubber dam for process of treatment, and that will be a really nice and efficient way to get your rubber dam inverted in between teeth. So perfect. Let me just continue. I will put some glycerin gel. I don't do this in the patient mouth because patient has saliva. My patient here doesn't have any saliva, so I have to help myself with a lubrication. So basically we use some glycerin here, but one more time, for patient no need for that, because saliva helps you to do that isolation easily. Okay, let me move my patient this way just to be able to make proper rubber dam isolation. Okay, I will not go in details now. I will just go between teeth here, between canine and premolar. And then before I will continue opening other teeth, I will have to stabilize my rubber dam here on that part. And you can put clamp, or if you have, for example, pretty tight interproximal contact, you can just take the part of the rubber dam, the piece of rubber dam like this, rubber dam cord we call it, and you put it between teeth like this. So you will stabilize your rubber dam and the rubber dam will not jump out, and you can continue moving your rubber dam between rest of these teeth. And then we will put frame. Okay, same here, same here. If, for example, interproximal contact too tight, before you will take your rubber wedge, you have to take some floss. You make initial inversion here. Okay, and then we will take another rubber wedge. We take it from the rubber dam. Another rubber wedge to stabilize this part as well, and then we can put frame. Okay, we can put frame. When we do cementation of veneers or crowns or whatever on the upper jaw, personally I prefer to use frame in non-classic way. So basically we use this frame when the bar is up. Okay. Many of you know why we do this. If you don't know this trick, I will show you later on why we use bar opposite. You will see it really interesting and efficient. So we put the rubber dam over the frame. Okay, we move from top the rubber dam, put this rubber dam on the frame. So there is no problem with patient's nose. You see, this is nose, this is the bar, patient can breathe, everybody is happy. So don't be afraid to use rubber dam in this specific way. This specific way will help you later on to get a really good inversion of the rubber dam with floss. Now I will take some floss to make a normal inversion, because once we expose teeth and we put rubber dam on the frame, afterwards we have to make inversion. Inversion is an important step, because if you will forget to make invagination or inversion, you may get some leakage of saliva or bleeding, and your adhesive protocol will be compromised, will be not complete and efficient. So you take floss, and with floss we go between teeth, one by one, like this. Move it to the sulcus, move to the sulcus here, see, forward and backward, one more time, forward and backward, done. Same here, forward, backward, pull out, from distal area, forward, backward, pull out. Then we continue, canine lateral incisor, same, forward, backward. You can use a plastic instrument or spatula or probe to invert your rubber dam, but personally I prefer this method with floss. It is more efficient. Okay, more efficient. And once you're done, don't forget to take mirror and to check if you have proper inversion from palatal side. Because if you make a really good inversion from buccal side, but from palatal side the inversion is not complete, it's bad rubber dam isolation. So for palatal side, for example, you can use your plastic instrument, as you can see here. You just invert your rubber dam with plastic instrument here. It will be easier now because you have already provided some steps of inversion with floss utilization. Okay, good. In our case, we have supragingival preps, so isolation is pretty easy. But what I would like to say, by the way, the most problematic parts with isolation comes from our preps. Okay, if you prep too deep, it's pretty difficult to isolate. Okay, I understand that sometimes we have to go intracervicularly. We have to prep intracervicularly in case when patient has a high smile frame, the teeth are discolorated, and we have to mask transition between veneer and the tooth. In this case, we prep intracervicular, so we localize finish line within sulcus, but don't go too much deep. The halfway of the sulcus is more than enough, or even 0.2, 0.3 millimeters under sulcus will give you a good result. Okay, so in this case the isolation will be pretty simple, and in that type of isolation, to get your let me just check, show you, sorry, I will go for higher magnification. To get finish lines exposed better, we can use additional isolation tools like clamps, for example, or you can use floss ties. Personally, I prefer to use floss ties if I can, because if you will put clamp has the arch, and arch sometimes is a problematic part when you have to work around the tooth with a brush or with a floss or with a scalpel blade, and this bar is always on your way. With the floss ties is never happen, because you can have a lot of space around the tooth. So if you can use floss, do this. When you can use floss, when you have pretty extensive or big palatal bulbosity on the tooth, and your prep is gingival level or supragingival definitely, or intracervicular just at the beginning of the sulcus. In this case, you may use floss ties in easy ways. Look, now we have pretty much finish line exposed by floss tie. Okay, if you don't know how to work with these floss ties, how to prepare these floss ties, I will refer you to our YouTube channel. You can go for playlists, and you will see 1 minute series, and episode number 3. Episode number 3, I'm showing you step by step of the preparation of these knots for rubbing isolation. Okay, so they have to be prepared by your assistant, by the way, so you will not lose your time asking your assistant to prepare them during the process of treatment. They have to be prepared in advance, and you just ask your assistant, give me please 2 or 3 or 4 or 5 or 6 or 10, and you'll get them immediately. Okay, your assistant will give you immediately this amount that you need. So here also we have our rubber dam placed, we have inversion, now we have exposed finish lines. Okay, if you would like to get more exposure of the finish line, look, like this for example, in this case you may use your frame. Now it's time to work with this frame that is upside down. You will put your floss, the one of the floss, underneath like this. Okay, and then you will make a simple knot here, first one, and then second one. So you will get your floss tightened to the frame, and you will have more exposure, or let's say you will have more retraction of rubbernum and soft tissues by floss tightened to the frame. This is the trick. I will do it on both teeth. And then I would like also to say that another tip with that type of isolation is not to cut these free floss ends. Don't cut these free floss ends. Keep them, okay? They will be really helpful for you when you will do finishing and polishing process after you will cement all of your veneers. Okay, before doing process of tissues preparations with bonding agents, be careful with inversion again, because sometimes when you tight floss too much, you can get some margin opening on the adjacent tooth, like in this lateral incisor. So I will have to invert better. Here, see, there is not enough inversion, so I will make better inversion in case to make my cementation process stress-free. Okay, great. So now we have done our isolation, and we are ready for another steps. We will prepare two surface for cementation process, and we will discuss with you three clinical cases or three clinical conditions. The one when you have everything in enamel, okay, just no denting, no fillings, nothing, just enamel. Another thing is when you have enamel and some exposed dentin. And the third one will be enamel and filling, or enamel and IDS. And I will show you step by step now how do we prepare surface of the tooth for bonding, considering these different clinical situations. In any single clinical situation that was mentioned, I always do sandblasting. Okay, so if I isolate my case as here, so basically I have several teeth good isolated, I can use sandblaster for group of teeth. To protect adjacent teeth, I'm using metal band, metal strip, okay, metal strip, because Teflon will not protect them, but metal will. And I will take my sandblaster, intraoral sandblaster. I will use aluminum oxide 23-27 microns, okay, with water. So I'll put some suction and we'll do some sandblasting. Before I will do sandblasting, especially if you have IDS area where you have some filling, and in order not to re-expose dentin, sandblasting has to be really quick, like 3 seconds. Done. Okay, don't play too much with sandblaster because you can re-expose dentin again. That's it. It is enough to get proper sandblasting, just few seconds, and to get the surface ready for bonding. Okay. The surface of teeth are clean. We need to do sandblasting when you have filling, to get some micro-mechanical retention. I do like to work with sandblaster also when I have just enamel, just to clean enamel, and everything will be ready for bonding properly. Okay, so now I will take my metal band out and I have to do another try-in. So basically we do 2 types of try-in. The first, once you remove provisional restorations and before you place rubber dam. The second will be done now, because when you place rubber dam you have to be really sure that you have exposed all these margins, and you have to be sure regarding pathway of insertion of your veneer and position of your veneer, in order not to get some misplacement of the veneer. And as I mentioned, this veneer is already siliconized, and I'm not afraid to make a try-ins in anyways, but also teeth are clean. So I put my ceramic veneer on the tooth surface just to check the fit, just to check the way I place my veneer, just to understand the position. Okay, and another thing, I would like to see if I can, for example, bond 2 central incisors at the same time. In my case, if you remember, I didn't make an adjustment, so let's pretend I will have the same problem in a clinical case. If I cannot place 2 veneers at the same time, like this here, I would prefer, in order not to get misplacement, especially on central incisor, is to bond 1 central, then another one, okay? And then I can bond 2 laterals, 2 canines, and whatever. But in this case, if I have some doubts and fears regarding placement of my central incisors, I prefer to be really 100% sure regarding the position of 1 veneer, then regarding another one, and then I will bond this one, and then I will show you what will happen later on. Okay, so this veneer was siliconized. I made try-in, and even though the surface of tooth was clean, there is still some, let's say, potential risk of some contamination or something that may go into your veneer. But again, it's not a problem for siliconized veneer, but just to disinfect the siliconized veneer. And another important thing, to remove inactive or non-active layer of sealant that is here already in the veneer, we may use ethanol. One more time, once you put sealant on the surface of ceramic, the sealant will react only by molecular layer, which is really super thin, okay? And the rest of sealant is non-active, and it has some thickness, and we can remove it in an easy way with ethanol. So what I will do now, while I will be preparing teeth for bonding, when I will edge them, I will bond them, or whatever, I can put my veneer with sealant already sealanized into ethanol, okay, and keep my veneer inside ethanol. By that means, I will disinfect my veneer, and also I will remove non-active layer of sealant. Okay, now let's go for tooth preparation. As we discussed or decided in this case, I will cement one veneer only, and then another one. So to make predictable sealanization, or sorry, to predictable bonding process, I have to protect adjacent teeth in front of etching and in front of bonding. So for this we can use really simple technique, which is Teflon. Teflon is really thin. Teflon is not compromising fit of your veneer interproximally, and Teflon, especially for this tooth, Teflon will protect adjacent tooth from bonding. I don't want to contaminate my adjacent tooth with bonding. That's why I will put some Teflon. Or instead of Teflon, what you can use? Instead of Teflon, you can use metal band. But Teflon is thinner, so there will be no problem with interproximal area. Okay, so we just put Teflon in between. This one is bad. I will take another one. What happens with my hands? I think that not Teflon bad, my hands are bad. In this evening. Okay, yeah, basically it has to be really fast, not like I showed you, and not perforate. Oh my God. Okay, let me do another thing. I will take a metal band to protect adjacent tooth, like this. Basically, I use metal bands in most of the cases. Like this can be done, okay? Like this. So, and it is faster, you see. If you use Teflon, just a tip to stabilize your Teflon, because when you will rinse, you will dry, Teflon can fly away. So in this case, what you can do is just you take a flowable composite and you will stabilize your Teflon towards rubber dam, you see, with flowable composite, like this. And then you can dry, you can do whatever you want. Whatever you want. Okay, good. We're ready for another step. Now we will do etching, okay? So the first scenario, we have all enamel. And it doesn't matter what type of adhesive system you will use. I mean, total etch adhesive system or self-etch adhesive system, you still have to etch enamel. So we just take phosphoric acid. Okay, we put phosphoric acid all over enamel. I also really like to work with this type of brushes. Why I like to work with this type of brushes? Because I can go between teeth like this, gently, because I have to prepare that enamel also with phosphoric acid. Okay, and then we just wait 30 seconds, 30 seconds. And then we will rinse. And then we will dry. Then we will rinse, then we will dry, and then we will apply bonding agent, okay? After rinsing, after drying, we apply bonding agent. So this is the easiest scenario and more predictable and more efficient in adhesive dentistry. But if we have dentin exposed? Let's do another scenario. Let's forget everything that I did before. We will do now, we will simulate, we will imitate case when you have, for example, here, exposed dentin, okay? So we're just going to the preparation of the tooth from the very beginning. Second scenario, again, forget about the one that I showed you before. So now, it will make a big difference in case if you use total edge adhesive system or self-edge adhesive system. If you use total edge adhesive system, you will edge enamel and you have to edge dentin. In this case, you have to edge dentin no longer than 15 seconds, okay? If you use self-edge system, you will edge only enamel and you will not edge dentin. This is the rule. So it will look like this. I will put phosphoric acid on enamel only. Okay, leave it for 20 seconds. If I will use self-etch adhesive, I will leave my phosphoric acid in enamel for 30 seconds, okay? For 30 seconds, then I will rinse and then I will dry. If I'm using total edge system, I keep my phosphoric acid in the area of enamel for 20 seconds. Then look at what I will do. I will take my brush and I will spread etching gel to the surface of dentin. Then I count for 5 and then we rinse and dry. Okay, so let's pretend that we did it. What was important in case if you are using total etch adhesive system? You have your etching gel on enamel for 20 seconds. Then you spread with brush your etching gel to dentin. Once all dentin is covered, you count for 5 seconds only and then you rinse. Literally, we are not etching dentin for 5 seconds. But once the first drop of the etching gel will appear on the surface of dentin, the time is starting to be counted, okay? So in case not to over-etch dentin, we're not counting for 15 seconds because it will be over-etching. But when we count for 5 seconds, it's still not 5 seconds, it's more than 5 seconds because the first drop was bring before and you have to stop counting once everything will be rinsed out. So basically counting just for 5 means that you will have your etching gel on the dentin for maybe 10 or 12 seconds or even maybe 15. Okay, so if you use self-etch system, we are not etching dentin, just enamel, and then you dry and you are not afraid about anything, you just dry for 0. But when you etch dentin and you are using total etch adhesive system, we have to follow wet dentin bonding, and the problem is that still nobody knows how wet is wet, okay? Because if you will over dry dentin, you may get some postoperative sensitivity. If you will have over wet dentin, you may have still postoperative sensitivity because bonding it will be not efficient in the area of dentin. So let me show you how do I dry. If I'm doing total etch process. So I just dry Rabidem. I'm just drying Rabidem. See, I'm not drying tooth. Then I'm drying adjacent teeth. Adjacent teeth. Then I'm drying from palatal surface. Then I'm drying tooth, but from enamel, so not directly, but just this way. And then I'm taking my suction without cover and just take some moisture straight from the tooth surface, okay? And then after that, what I'm doing, if I'm using fourth generation of adhesive system, I'm taking primer Okay, the first generation of adhesive system is when you have separate primer and separate adhesive. I'm taking primer, the first bottle. I will put my primer here, and I will make massage for 20 seconds in the area of dentin. You can use multi-coated of primer, by the way, and then you just dry it for 0. Just dry, and then you take second bottle, which is adhesive, and you put adhesive both on enamel and dentin. Okay, if you use 5th generation of adhesive system, which is still total edge, it's just one bottle system. In this case, you just apply from the very beginning to enamel and to the dentin in the same moment. If you are using 6th generation of adhesive system, which is a self-edge, but classic self-edge, when you still have acid primer as a separate bottle and adhesive as a separate bottle. In this case, once you dry the surface, you take still primer, you do 20 seconds priming in dentin area, dry, and then you take your bonding agent and you put your bonding agent all over surface of enamel and dentin. What I would like to point, okay, in this case, if you will use self-etch system, especially 7th generation of self-etching system, one bottle systems like multi-purpose, you have to be really careful in case when you are utilizing dual cure cements, because some of dual cure cements are not compatible with this self-etching system. So if you are using dual cure composite systems for cementation, like cements, resin cements, dual cure resin cements, it's better to use bonding agent that is recommended by manufacturer of this resin cement. Okay, so that was second scenario. Now we are going to the third scenario when we have enamel and we have filling. Let's pretend that this area is filling. Okay, this is filling. This is IDS and big filling there. Okay, composite, because there was caries defect, for example. So what I will do in this case, so now let us forget everything that I did before. So we just have these two at the very beginning. And I will do this thing. I will etch enamel with phosphoric acid, just enamel. For 20 seconds, okay? If you are using self-etch system, okay, self-etch system, again, you will just, after 30 seconds, you will rinse it out, dry, and then you will go for the second step that I will show you. If you use total edge system, so we keep acid gel on enamel for 20 seconds, then we spread it gently on the area of dentin. Now we count for 5, 1, 2, 3, 4, 5, then we rinse. Why so? Why I'm doing same as I do during the second option when we have exposed dentin? Why I'm doing the same here, even though that I have filling? The problem is that if you have filling and some ideas, once you made sandblasting, theoretically and also practically, you can re-expose dentin again. So in this case, I don't know if I re-exposed my dentin or I did not. But if I re-expose dentin, I don't want to over-etch this area, okay? That's it. So in this case, I just work again for this 10, 12 seconds, okay? Why do we need to etch filling? We will etch filling because of cleaning, just to clean the surface, and that's it. We don't need to etch filling, but theoretically it can be dentin that was exposed. In this case, if I'm using total etch systems, I have to etch my dentin. The best scenario is when you are not exposing dentin, definitely. We are not trying to expose dentin when we are doing sandblasting. This is not for exposing dentin, but it may happen. A little bit, but it may happen. So in this case, again, we will dry gently, not to over dry. Then you take your suction, take some water out from this area. When there is filling, it has to be dry. Okay, and now, when we have filling here, once you etch, okay, enamel, It doesn't matter what type of adhesive system we are using right now. Okay, total etch or self-etch doesn't matter, but we have this filling here. So after etching, what I do, I take sealant, the same sealant as we use for ceramic. I take some sealant and I'm using a really thin brush like this, and I will put sealant exactly on the surface of this filling, trying not to contaminate the rest of the two surface. Why do we use sealant here? If you have composite filling, composite has some glass particles as filler, okay? When you sandblast, you expose these glass particles, and sealant is the thing that has chemical reaction and chemical bonding to glass particles. So we will have mechanical retention, and also we will have some chemical retention as well, chemical adhesion as well. So once we have the sealant here, we need to wait until it evaporates, or you can accelerate the process of evaporation by light cure. Basically, the main reason of utilizing light cure is not because we light cure sealant. The classic sealant is not light curable. When we light cure, we generate some heating, okay? So heater effect accelerates chemical reaction. This is the thing, but not overheat the tooth. So once it's done, we will apply adhesive. In this case, we will apply adhesive to enamel or to dentin. In case if you still using, for example, fourth generation of adhesive system, which means you have separate primer. In this case, I will put some primer here in the area potentially or around this filling, then dry, and then I will put adhesive. Okay, then I will put adhesive. So I'm using now a filter, and I will put adhesive both on tooth surface, filling surface, or exposed dentin surface, or if it was all enamel case, I will use bonding agent. We have to. So we'll put some bonding agent on the tooth surface, and also I will take my veneer from ethanol. I will dry my veneer from ethanol. Veneer is already silanized, you remember. I will put some bonding agent to ceramic surface. Okay, and I will put adhesive all over tooth surface, all over tooth surface. This is what we have to do. And also I'm using brush, you see, because I can use my brush, moving brush between teeth to get proper bonding between teeth. So we just put all over tooth, all over dentin. We have to have a really thin layer for bonding agent here, really thin layer, super thin layer on both, and we are not light curing either on the tooth surface, neither from ceramic veneer surface. Why we are not light curing adhesive on the surface of veneer and also on the surface of tooth? Because, for example, if you are using thick adhesive like Optimon FL, for example, which is pretty thick and filled, it may compromise fit of your veneer. Okay, if you use thin adhesive and you will dry it, actually you can light cure, but still some adhesive can go between matrix and the tooth, between the Teflon and the tooth, and if you will be not able to see it precisely, and then you will light cure, you may get some, again, compromise with the fit of your ceramic veneer. Considering the surface of ceramic veneer and the necessity to put adhesive on veneer surface, it's not mandatory, because once veneer surface is silanized, it can get monomer for chemical bonding from resin cement or from composite. So basically, the step of applying adhesive layer on ceramic surface is not mandatory. But if you will put adhesive on the surface of your ceramic, you will get your surface more wet. Okay, that will be better for cementation process. So we have our adhesive on veneer, dried, thinned, and on the tooth. And now I will apply some resin cement What type of resin cement to use we will discuss a little bit later. Just let me just show you some clinical steps. We apply some cement on the veneer. We apply some cement on the tooth. Then I'm taking a dry brush and spread this layer of cement all over the tooth, especially in the area of finish lines. Okay. Same, I will have to control if I have enough cement in the area of veneer. Okay, great. And then I will put my veneer on the tooth like this. See what I'm using when we are using floss ties and there is no clamp, there is no bar. You can use your finger to press gently here. But if it is not possible to use a floss tie and you're using clamp, and you cannot get your finger between the bar of the clamp and the tooth, you may use tweezers, or you may use a special instrument with plastic cover to press here, and you see that we have a lot of excess of material, a lot. Okay, so it's good. There is one of the methods to cement veneers. When you just put your veneer like this, some people say that you just can pre-cure, like 1 second pre-curing, and then you will take probe or explorer and you will remove this pre-cured resin in a really fast way. Personally, I'm not a big fan of this approach. I love to work a little bit differently. I just take brush and I start to remove the major excess of material by brush. And in this case, I will explain you cement that I like to work with. I really like to work with light curable cements, because if I use light curable cements, I'm not limited in time. Okay, so I can play with brush here as long as I want. Why it is important, you will see later on. So I'm just taking out the major excess with a brush. Before I will do something, I just take excess with brush like this. Okay, then what I can see, I can double check if fit is correct, if position of veneer is correct. If my fit is not correct or position is not correct, I can see what I can do. I can move. So I can be really sure that position is correct. Another thing, just take a look here. I'm not pressing, okay? Now look, if I will press, what happened? I will just magnify to get you these details, because they are small details but they are really important. Just take a look. See, I press, one more, again. See, it's a small movements, but it is. And imagine if you will just pre-cure your resin cement, but your veneer has already moved from the initial position, you'll have a really thick layer of resin cement underneath your veneer, which is not good because it's softer than ceramic, and you may get even cracks here. So this is not a good idea to make a pre-curing. I press, okay, hold. What I can do, I can remove this excess also. And then from the area of central incisor, I can take out this matrix. From the area of lateral incisor, what I can do, I can take my floss, because still I can have some excess of material between teeth, but it's not a problem because we can take floss. Okay. We can go between teeth with a floss and clean the interproximal area with floss. Then, what we do then? I still continuing pressing on the veneer gently. Yeah, for example, sorry, but we forgot to remove excess of material from palatal side. That is also important. Just take it out with your brush. Okay, you have to. Okay, so now I will press a little bit from buccal surface, from buccal surface and from incisal edge a little bit like this. See what happens again? I press and material goes out. Let it be here. I press and I hold. And at this stage I will light cure, my assistant actually does it, from palatal side. We light cure from palatal side for 20-30 seconds. Why from palatal side? The reason number one is that my fingers are from buccal side and I cannot get my lamp on my fingers. But there is another reason why, because we are light curing through translucent object, which is tooth, okay? And you can see that the light goes through, and the power of the lamp is decreased by thickness of the tooth, and the light that gets into the surface of cement is making so-called soft polymerization, and this way we decrease stress on cement, okay? So this 20 seconds is enough to stabilize your veneer completely, okay? Now you can take your fingers out, and if you want, for example, you really want to do this pre-cure, like 1 second, see, from the buccal surface material is not cured yet, so you can just pre-cure, and then you can take your probe, or you can take your scalpel blade, or you can take whatever you want, and you can cut this pre-cured cement easily. See, it's easy to be removed now. It's easy to be removed. Or there is another thing which is also important and practical. For example, let us pretend or assume that in our case we had some bad fit of veneer here, a small gap, a really small imperfection was here. So when I light cured veneer from palatal side and there is an excess of material here, I will not take it out with the scalpel blade. I will just take my brush, will spread this composite gently with a brush like this, for example. Then I will light cure this area for just 5 seconds. Okay, and then I will remove this holder, and then I will put some glycerin gel from this area and also from palatal side. Glycerin we use just to create environment when the final light cure will be done without oxygen. So cement that is underneath this glycerin gel will be light cured without oxygen, and there will be no oxygen inhibited layer. So we take 2 lamps and we light cure from both sides, from palatal side and from buccal side, for 30 seconds. Okay, so this is the glycerin gel. Again, it doesn't make anything by itself. When you light cure through, cement is light cured without oxygen, so there will be no oxygen inhibited layer. You can remove oxygen inhibited layer also with another thing, with ethanol, or with ethanol. So done. Okay, good. Now we will just rinse out this glycerin. We can take out Teflon. We can take a floss just to check proximal spaces, proximal areas, to clean some cement between. In this case, there was a little bit, so we take floss. If you have problems with taking out cement, but if you would use floss before you light cure, there will be no problem. But just if you will have problem, you can take a metal strip perforated with a saw, and you can go with a saw between teeth like this. This is non-abrasive metal strip, just perforated, and then when you move this strip forward and backward, you may get some cement inside these perforations, and in this case you keep your interproximal contact and you are not making ceramic rough. Okay, so now we will do some polishing, but in this case I will show you also why we are not cutting these free ends, as I mentioned before, because I can pull them, and see what happens when I pull them. I can open more space, more area here for cleaning. I really like to work with hand scaler like this one, so we can go with a hand scaler really deep. We can even push floss more down with a hand scaler and just smooth transition. Remove this bonding agent here. Okay, that's fine. You can also use scalpel blade number 12. Number 12. Okay, good. If it was correct, this is the final step of your process of finishing. If not, for example, I have some resin cement here, I can go to another step. I will just take a really small size of orange softflex disc, 5,000 RPM only, just 5,000 RPM, and we will go for polishing of this area with a small size of disc. My mandrel is not new one, that's why it happens that disc flies away. Disc is flying away. Okay, so yeah, take another one and just polish this transition. And I'm pulling with floss. That will help me to get a really good retraction. Okay, then after disc, I really like to work with another instrument, which is spiral. Also softflex spirals. There are two colors, beige, like this. It's pre-polishing. It's flexible. You see, it's really flexible, so it can get really even between teeth. 5,000 RPM with a little bit of water. And then I'm taking another thing, which is spiral also, but purple. And purple is polishing one. With the same speed, with a little bit of water, you go this way. Okay. So basically it's done. It's done. The polishing is good, integration is good, everything is good. Okay, now we are ready for another central incisor. In clinic, all this process takes not that much time like here, because I'm doing a lot of explanation, showing you some tips, tricks, I'm working with assistant, but it has to be relatively fast. But now I have to cement another one, and the thing is, if at the very beginning of my process of bonding I understand that I will bond one central incisor and then I will bond another central incisor, I will sandblast only one central incisor that I will bond my veneer to. So let's assume this central incisor, adjacent central incisor, was not sandblasted. Now I will sandblast this central incisor, and I will take, see, there is another piece of cement here, so I clean it. I will put my metal band. It's really important to get this metal band to protect adjacent tooth. When I was cementing this central incisor, I can get some bonding agent or some cement here. So now I can take it out easily with sandblaster. Okay, so there will be no bonding agent, nothing. And after this, I will remove my metal band, I will dry everything, and I will try in my veneer. In this case, I will have some problems with proximal contact. So what I have to do in this case? In this case, I have to take a wedge. I will put wedge from palatal side. Okay, and then I will do another try in my case, you see that I have a gap because the phantom teeth are mobile. In the patient case, it will be not that such a gap, but let's assume there will be still problems with interproximal contact, but you have your wedge. So in this case, what we have to do, we take an articulator paper again, put it here, take our veneer again, hold, take paper here, you will see some super contact, and then you can make adjustments of this super contact with brush on the veneer that you will bond and also on the veneer that you have already bonded. On the adjacent veneer you can use discs just to make some finishing and polishing, just to make interproximal contact not that tight. And then after that I will go for the same process of bonding as you saw. This veneer is already siliconized, so I will put it into the ethanol. After trying again, I put it into the ethanol, and then I go for etching, rinsing, bonding, and everything for the tooth that I will have to bond my veneer to. This is the thing. Okay, so I showed you clinical steps of cementation process. Now let us discuss a little bit regarding materials that can be utilized as the materials for bonding. Personally, as I mentioned, I prefer to use light curable materials to bond my veneers, and also overlays if I can, or crowns if the thickness is okay to be light cured through. I can use my light curable materials because I'm not limited in time. Another thing is that some dual cure resin cements have amine group that can be discolorated later on. So the color stability is under the question in some of them. And what you can use also, you can use specially designed cements, resin cements for veneers, light curable, for example, the one from 3M, Relay X veneers, like this one. They're a nice product, pretty comfortable to be used. They can come with a try-in pastes. You can use from materials from Ivoclar, from Care Company, from Takuyama. There are many companies on the market, which is not a big problem to choose the good product. You can also use composite materials, the restorative composite materials to bond your veneers. You can use highly filled flowable composite. This is a nice group of composites that manufacturer recommends to use as a final restorative materials. For example, for restoring cavities class 1, class 2, class 3, class 4, class 5, like a final restorations. Okay, that means that this material is filled enough to resist occlusal forces and also environment, and to be stable in terms of the wear process, and also color stable. Okay, so these materials can be used easily. For example, Genial Universal Flow from GC, or there is one from Takuyama, there is one from Ivoclar. They're highly filled flowable composites. They are not the same as, for example, SDR or bulk filled flowable composites. Bulk filled flowable composites or SDR composites are good for dentin restoration when you do direct composite restorations, but for cementation it's better to use highly filled restorative flowable composites. Or some clinicians, they really like to work with a heated paste composite. They heat composite up to 50 degrees temperature, and then they bond their veneers with normal packable preheated composite. Personally, I don't like this option also because when you play with fitting of your composite, even though it is heated, the temperature goes really down in a really fast way, and you have to apply more forces just to stabilize or to fit your veneer on the surface. And if you will apply too much forces and your veneer is really thin, you can break it. Okay, and there are no huge advantages and benefits of paste composites in front of highly filled flowable composites. So basically I prefer to utilize highly filled flowable composites to cement my veneers. Light curable materials can be applicable with any bonding system that you will utilize, so you don't need to use a special bonding system for special light curable composite. Okay, what else? Another thing that you have to admire and to respect also is that after cementation, especially when you have some problems of the marginal fit in some areas. If you will use highly flowable composite and then you will polish it, everything will be fine. This area will be polished and will be fine. To be safe, as I mentioned at the beginning, you better to use the same shade of or similar shade of material as the shade of your ceramic veneer. You can use any hydrofluoric acid from any company. You can use any sealant. As I told you, the one that I used was from Bisco. There is a similar product from GC also, ceramic primer to bottle system, so they work perfectly with the ceramic bonding procedures. Okay, the final stages of this online masterclass, let me also point some things regarding postoperative sensitivity. The main reason why there is a postoperative sensitivity after you make bonding process of your veneers is that you are not respecting bonding protocol. For example, you over edge dentine, or there is the water, or whatever, or you didn't apply enough primer, or you didn't apply enough bonding agent. You dry too much, for example. You are not using Rabidam or whatever. In case when you do, for example, IDS, okay, immediate dentine sealing at the day of preparation, you may get really low percentage of postoperative sensitivity because a dentine will be already sealed with adhesive resin. Okay. Another thing, if you have your dentine fresh now, you sandblast, you have your dentine fresh, you didn't make your IDS, and you will prepare your tooth surface right now, including dentine. What theoretically may happen is when you will get your composite resin or resin cement with your veneer, and then you light cure, there is a shrinkage of material, and the direction of the shrinkage is like is the surface shrinkage, is the 3D dimensional shrinkage, is the internal shrinkage. Okay, and the direction is towards the adhesive surface. In our case, we have two adhesive surfaces. We have tooth and we have ceramic. If ceramic will win, you may get some deep bonding in dentin area, and your patient will complain after cementation that he or she cannot touch the tooth because there is like an electroshock and everything is painful because of deep bonding. But again, if you do IDS at the day of preps, you will have no of this problem. Okay. Another thing which may cause postoperative sensitivity, if you respect all these bonding steps and protocols, you know exactly how to use your adhesive system, you follow protocol, you follow instruction, okay, you made IDS, everything was perfect, but patient has some postoperative sensitivity. Maybe when you were cleaning the transition between veneer and the tooth, you was too much aggressive with hand instruments like a scalpel blade or with a curette or a scaler, so you can make some scratches in cementium area, so that postoperative sensitivity will disappear within few days or few weeks. So it's just mechanical problem. In the rest of the cases, you may get good integration of your ceramic veneer with the tooth. Respecting the bonding protocol, you will get a really good long-term survival rate for your veneers. And don't be afraid, they stay, they can be bonded for a long term, for many years. And another problem with the veneers, by the way, that I didn't mention, is the function, okay? And if your bonding protocol was perfect and you did not respect, for example, function, you will not have debonding. You'll have chipping of your veneers. If you have debonding, it's not because of the function, it is because of the function and problems of following of adhesive protocol. Okay, so guys, I think that we are done with the main program. What I would like to say, first of all, I would like to say thank you all and invite you to a live Q&A session. Just after 10 minutes break, we will meet you again for Q&A session. For those who are watching us not live but in the record, thanks for watching us. Okay. And my friends, I would like to make an announcement. We are preparing another webinar, another online masterclass that will be next month. So we will continue veneer series, and we will do a topic that many people ask us to do. We will do a topic about designs of veneer preparations for molars and premolars. So we will take 3 different types of preparations. We will take molar tooth for type 1, veneer preparation for molar tooth. We'll take premolars, and we will do type 2 and type 3 veneer preparations for molars and premolars, step by step live, with deep explanations, with everything as this time. Okay, so guys, see you in 10 minutes. For those who are watching us in record, see you next time. Bye. Okay, yeah, we're live again. Hello guys, one more time. I don't know what time is now in your countries, but in Ukraine it's almost 10 p.m. and we're still full of energy because we actually discussing with you a really interesting topic that is on-demand problems and protocols for veneer bonding. So let's go straight to your questions because we have pretty few interesting questions here, and I would love to answer in my best way. Okay, so the first question is from Prodent. What is the name of the black box that you keep the veneers? It was the box, actually the manufacturer name is Smile Line, and the name of product, the name of this box is Veneer Me. The author of this box is Galib Gurel. Very interesting and very ergonomic actually device for preparing veneer surfaces and crown surfaces and overlay surfaces for bonding. It's actually I do recommend. Okay, so the next question is from Lika. If after cementation there is high spot when patient occlusion, can I grind from the veneers and how? So if you have to adjust occlusion after cementation, it's possible, no problem with this. In that case, you may use red and yellow diamond burrs with high water cooling also. And after making some adjustments, you have to take rubbers. You have to ask your dental technician exactly what kind of rubbers he uses to polish ceramic. So you have to use the same rubbers to polish in the same way. And ask your dental technician also to provide you paste. So you will polish it with rubbers and with the paste, same as your dental technician does in dental lab. So in this case, you'll get really highly polished surface, and there is no risk that opposite teeth will be worn out because of the scratched ceramic surface after occlusal adjustment. Okay, thanks for the question, by the way. Al-Hamed, I could not reach the live course. I'm waiting since an hour. All people were watching us live. Some people had some problems with access, but these problems were solved in advance in our let's say by our team of support. So I think you should write down into the messenger where you was registered for this course. Jan Valando, if I'm pronouncing name correctly. So I have 4 questions. First question: what do you think of IvaClean from Ivaclar? It's for cleaning ceramic surface from contamination after intraoral try-in. It's a pretty good product, actually. Really good product, was designed for cleaning. Personally, I do not use this product. I don't feel any really necessity to use this product in my practice, but actually the product is pretty good. So if you use it, go ahead, it's good. If you don't have sandblaster, what is the alternative? For cleaning to surface, you can use pumice paste, or how to say, it's fluoride-free pastes, abrasive paste, just for cleaning and make some scrubbing on the surface. But the effect, it will be a little bit different, because sandblaster actually is like a micro etcher, and you'll get a little bit different effect than in comparison with pastes. But if you don't have sandblaster, you can use this abrasive paste as not alternative, but like a step for cleaning of the tooth surface. And what I would like to say, that sandblaster is pretty good investment. It does not cost so much, so I think that you can afford to buy a good sandblaster, and you will enjoy doing sandblasting. M.Z. Thank you for the great video, love it. Thanks for your compliments, my dear colleague. I have two questions. What to do if we accidentally removed too much tooth structure? Okay. And the second question is, will you have inlay, onlay, overlay video, please? Thank you. So, my friend, if you will remove too much tooth structures, unfortunately, sometimes it happens, and you expose too much dentin, I prefer to go for IDS procedure that will give me a less postoperative sensitivity. And also, it's proved scientifically and clinically that IDS gives you also better bonding to porcelain veneer. Regarding your second question about inlays and overlays, actually we are planning to do that type of videos in future. I cannot tell exactly when because we are continuing the big and powerful series about veneers. And the next series, by the way, the next online masterclass will be next month, and I would do an announcement right now for you, for all of you who watch us live. You will get a special offer. The topic will be veneer preparation, the strategies and tactics of veneer preparations for posterior teeth. Will be molars and premolars, veneer preparations for that type of teeth, and we will do at least 3 different types, 3 different teeth. So keep in touch. Another question from Jan Valando. If we use highly filled flowable composite, do we need to bond the ceramic surface? You have to bond ceramic surface all the time. It doesn't matter what type of cement you use. The classic protocol, you add hydrofluoric acid, then you do silane, and then you can put bonding agent, or you can skip bonding agent, you can go straight to composite. So if the question was if you need to use bonding agent on ceramic surface if you use highly filled flowable composite, the answer will be you can do both ways. You can still put some bonding unfilled resin on veneer surface, dried and not light cure, or you can go straight to utilization of highly filled flowable composite. Personally, I prefer to put some bonding agent on ceramic surface, and then I go with my highly filled flowable composite. This is my preference. Another question is, there is a zirconia veneer. How do you manage the bonding cure during final placement since the light can't pass it? First of all, I'm not using zirconia as material for veneers. I don't believe in bonding, in good bonding strands between zirconia and teeth. I'm really personally do not recommend you to use zirconia for veneers, not for crowns, for veneers. I do believe in glass ceramics, okay? When I can etch with hydrofluoric acid, I can use silane, and I can bond it properly. So this is my philosophy. No zirconia for veneers. That's it. Sakina, the question from Sakina, if a tooth is discolored, do you suggest masking cement? If so, would the translucency of veneer match the neighboring tooth? In case of discoloration, you have to discuss this case before with your dental technician. This is important because if you would decide to use masking cement, for example, which is opaque, you may make a mistake. So in this case, you have to provide to your dental technician information about existing color of the tooth. Okay, you will take some pictures. You can take pictures with shade guides, with core guides, and then dental technician will make a decision what type of ceramic he will have to use in order to mask this color. In some cases, you can do try-in. In some difficult cases, you can do try-in just to be really sure that everything is all right, and then you can reschedule your patient for final restorations. So what I'm trying to say is that I don't like to try to fix discoloration problems by cement color. We discussed with dental tech, and we try to fix this problem by ceramic material that my dental technician utilizes. This is our strategy, and it is much more predictable. Okay, Islam is having this question. What if I get space, like what happened with the veneers in this video? How to make sure that no space will be there between veneers after cementation? First of all, we used Phantom, and teeth in Phantom are not stable. This is the problem. When you put wedge, they will not go back sometimes. In patient cases, everything should be all right. So you have to be sure if veneer fit before you place rubber dam. Okay, so you do try in. If they fit, if there is no space, perfect. Then you do a rubber dam isolation. And in case if you have tight interproximal contact, you have to put wedge. I was explaining this. You have to put wedge. This is really mandatory. And then, if you will need to adjust interproximal contact, you will do it really super gently. Otherwise, I know that some people can do gently adjustment. Some people can just do a really rough and quick adjustment. In this case, you may lose interproximal contacts definitely. So what I suggest is to put wedge if you can. Then you put this 8 microns articulator paper, which is articulator foil between teeth. Then you move it between, remove, and actually the ideal contact is when articulator paper sliding slightly. It's not like a living, you can do easily backward and forward, but you can just, it gets some resistance, small slight resistance. This is the good interproximal contact. So in this case, you can be really sure. So after removal of the rubber dam, everything will be perfect. Okay, another question is from Ayman Hadi. Thank you for the very useful clinical tips. In case of misfit veneers during placement due to excess cement, you couldn't check the fit properly. So after cementation, is there any way to fix this problem? For the problem, there is another message from this participant. This problem, all other than rare, do the veneers again. If I understood the question correctly, you have to be really super sure that veneer fit before you do cementation. That's why we do two steps of try-in: before placement of the rubber dam and after placement of the rubber dam. So if you have a bad fit of veneer before you start case, just during try-in, you have to redo veneer. Don't try to fix it. And we do also second try-in with the rubber dam to be again sure that rubber dam didn't change position of the teeth, and we could expose margins by rubber dam isolation, so there is no interference between rubber dam and veneer. And after that, we just do cementation. And during cementation process, before light cure, we remove excess with brush, and we can again double check if veneer sits on the finish line as it's seated before putting cement in. So we have triple type of control under fit of veneer. So I don't know what you can do else. It may help you. Okay, another question from Jan Valando. What would happen if we etch using high percentage hydrofluoric acid, 9.5% on feldspathic ceramic? Actually, 9.5% of hydrofluoric acid was specifically designed for feldspathic ceramic. So for feldspathic ceramic, you can use 9.5% of hydrofluoric acid. Nothing will happen. But you have to use it just 60 or 90 seconds, none more. Another question from Mohammed. If we have bad placement of veneer after light curing, how to remove it safely? If there is a really bad placement after light curing, that means you didn't control placement well. I did my best to show you all the protocols, all the steps, how can you control and how can you be confident that your veneer sits correctly. 3 types of control. I explained you that. But if it happened, in this case you have to redo. Unfortunately, you have to redo. So it depends again how bad is the fit after cementation. But there are two options to redo veneer, to remove veneer. You prep again, okay. And another thing is you can use erbium or water lace, and you can remove veneer with a water lace. Milan, if veneer Emax is debonded, which one protocol do you use to rebond it again? In this case, if I have debonding, I do sandblasting because I have to clean the surface from previous cement, and then I go for the classic bonding protocol. So basically hydrofluoric acid 20 seconds, 5%, rinsing, drying, then phosphoric acid just to remove salts if there are, and then rinsing, drying, then silane again, then unfilled bonding resin, dry, and then I use my composite cement for that. So the basic protocol. What is sandblasting? What is the sandblasting powder used? Is the question from Islam. Aluminum oxide. I'm using aluminum oxide, 27 microns. What about shade selection? What shade of cement do you usually use? My friends, I think that you did not listen me attentively during main session. So basically, I use the same shade of cement as my veneer. I explained you that. I use the same shade of cement that my veneer is. Ash, hi, thank you for your presentation. Thank you for watching us, my friend. Question from Ash. Would you ever do upper veneers where the lower incisor edges meet the veneer surface when patient closes in maximum intercuspation, instead of ideal of having lower incisor hitting upper palatal? So basically we have 3 points of view for that issue. First of all, some people say that ideal if teeth will touch tooth, when opposite tooth will touch opposite tooth surface. And others say that you can have opposite tooth touching ceramic surface. And these two groups of people, they don't like to get occlusal contact in between, in the area of junction between a tooth surface and veneer surface on opposite tooth. And there is a third point of view, they don't care. So you can just do whatever you want, but you have to get stable occlusion, no super contacts, good protrusive movements, good lateral protrusive movement, canine guidance, so that will help. Ahmed asking me another question. Thank you for this rich webinar. My question is, thank you, my friend, also. The question is, do you have an advice regarding organizing instruments for saving time? And what time is needed for bonding 8 units in Maxim protocol? Actually, yes, we have sequence of instruments because every single procedure that we do has its own protocol. So every single step is predicted, and assistant knows every single step. So we have organized every single instrument. My protocol that I showed you is a little bit complicated, let's say a little bit complicated, but what is good from this protocol is that we can be really confident that we bond our veneer properly, and the fit of veneer also proper, and it sits on its own place. And as you may understand, trying to take a good care about these small things, it takes time. It takes time. So for 8 veneers, it depends also on the case, but I can say so one tooth may take from 10 to 30 minutes. It can be like that. So average time that I spend for veneer cementation for one tooth is about 15 minutes for one tooth. So you can calculate how long it will be for 8 teeth. Sorry. Sorry. So another question from Ahmed. Last question, can I reduce ceramic proximally with burrs rather than rubbers? You can use burrs at the first step, but this is super important, you have to use special rubbers to polish your ceramic afterwards. This is must. Elias, the question from Elias. Hi, when it comes to bonding ceramic, you use ceramic bonding only or the tooth adhesive system first and then the ceramic bonding? Or the tooth adhesive is sufficient without ceramic bonding? Thanks. It's a complicated question. I cannot get you. I explained to you in very details the process I would do. For ceramic surface, let's do it one more time, just quickly and roughly. Ceramic, we etch with ceramic, we etch with hydrofluoric acid. Then we rinse, we dry, we put sealant. Then we wait, then we put bonding agent, unfilled bonding agent, dry, and then we wait. Tooth, we do etching with phosphoric acid, then we do prime, then we do bond. If you have dentin open, you do prime. If no dentin open, you just do bonding. dry, not light cure. And then you use your resin cement that you put in ceramic, and then you bond your veneer with this resin cement over to a surface that is prepared for bonding. This is a really classic thing that I don't know why do you have still questions about that. Yemen, question from Yemen. Thank you very much. Thank you very much as well. I want to ask is it necessary to do silane before bonding in 3M system, because the company told that only etching and bonding on ceramic surface. The new bonding from 3M, which is 3M single bond universal, they say that you can use it without silane. But to be honest with you, I actually don't believe in that. So I know that silane procedure and that protocol exists more than 25 years old, and it is proved scientifically and it is proved clinically. So I don't want to compromise anything in this good balance. So I use silane. Sakina, could phosphoric acid be used as an alternative to sandblasting? It's not an alternative. Sandblasting is not an alternative. Sandblasting is cleaning and making micro etching. Phosphoric acid etches, dissolves hydroxyapatite in enamel and in dentin, by this means creating a lot of millions of poros inside where your bonding agent will go to make micromechanical retention. The process of sandblasting and the phosphoric acid is a bit different, so it's not an alternative. MZ, hi, if you do IDS, won't it be too thick layer with the cement flowable as well? Actually, we do IDS when we prep teeth. IDS we do during preparation or after preparation. But we do 2 steps of preparation, then we do IDS, and then we go for a 3rd step of preparation when you will decontaminate enamel, refresh your finish line. And in this case, you can control if you make IDS in correct way in terms not to change the design of your preparation. So we control this process in order not to get problems with the fit of the veneer. And then only after this we take impression. Okay, so after IDS we take impression. Actually, we do 1st and 2nd step of prep, then IDS, then 3rd step of preparation, then impression. Okay, then impression. If you want to learn more about preps, we have our webinars. We have recorded our online masterclasses in our educational online platform that you may find easily on our website, en.belograd.com, and you can go to online masterclasses or webinars. There is a folder, and you may find previous series about veneer preparations and technical aspects of preparation, clinical aspects of preparation, when we discussed and we showed, like today, every single step with a really detailed and clean comments about sequence and protocols. Okay, another question. Islam, been listening, my friend, but sometimes your pronunciation is unclear. Yeah, this is the problem, because I'm not native speaker. I mean, the English is not my native language. That's why maybe sometimes I get some misspelling. But you know, sometimes when you listen the lecture or course by native speaker and they speak so fast, so sometimes it's difficult to understand actually what they are speaking about. Okay, so don't be upset. I'm not kidding. I'm joking. I'm kindly joking. Okay, great. So Manuel, greeting from Mexico. Hola, amigo. Ruta, hello. How are you, Ruta? I remember Ruta. She attended our course here in dental camp. So the question is, if we cement 8 veneers in one session, how do you prefer to start? From which tooth? If I cement multiple veneers, I prefer in most of the cases, let's say, in most of the cases, I prefer to start from central incisors. If I can fit them together, I do just 2 centrals, then I do 2 laterals, canines, premolars. So this is the sequence. Another question is by Ash, based on my previous question, would you personally be happy to have lower incisor edges on unsupported ceramic veneer. It's not, look, ceramic veneer is already supported by bonding to enamel. So when you cement, when you bond your ceramic veneer, it becomes like a whole piece with a tooth, like a one biomechanical substrate. So it's supported. This is important to understand. Or would you prefer to crown, to have supported ceramic? So crown actually is not that, sometimes is not that supported as veneer, because in crowns, especially when you have a lot of dentin exposed, you may get some deep bonding. So actually, I'm not worried to have contact in my ceramic veneer. I'm not worried in case, if occlusion is stable, okay? Again, protrusive, lateral protrusive, canine guidance, everything is perfect, so I'm not really worried to get some contacts in the veneer areas. No problem with that. Elias, what is the difference between putting one layer of silane and multiple layers of silane on ceramic veneers? When you put silane, you have to understand the principles of chemical adhesion that this silane gets. Only one molecular, you know, molecule, right? If I'm pronouncing this correctly, molecule. One molecular layer of silane gets this bonding, that gets this chemical adhesion with glass. Imagine how thin this molecule layer, it's almost nothing. So if you will do, and the rest of silane, by the way, is inactive. And if you will have multiple layers, you create layers of inactive substrate that may compromise your bonding strength, by the way. So in this case, one layer, and it is recommended after full process of salinization to take some ethanol to remove this inactive layer of silane, and then you go for bonding. This is an interesting point of view, and it is also proved scientifically. Ash, also on a very discolored tooth, would you prefer to use opaque composite? Actually, I answered this question regarding discoloration. I answered this question. We do cases with discoloration, and all responsibility comes to dental technician. But from my side, I have to provide information about the tooth, and dental technicians select the proper ceramic opacity in order to get this case done. Okay, so I'm not experimenting with opaque cements trying to mask discoloration. No, we select proper ceramic shade and also type of opacity of ceramics. Okay, Elias, again, one more question from this active guy. How thin we can grind the ceramic veneer after cementation to avoid later on fracture from occlusion? Theoretically, veneer, if veneer bonded to enamel, okay, bonded to enamel, theoretically the thickness can be 0.1 millimeter, okay. But what we do when we make adjustments of occlusion, this is the thing, okay. Most of the cases we do adjustments from palatal side or from incisal area, but in the frontal area, I do prefer to prep with butt joint, okay? So butt joint is just flat design of incisal edge. In this case, the thickness of ceramic, which is really thick piece of ceramic, is about 1 millimeter or 1.5 millimeters. So in that case, believe me, this ceramic is pretty strong. I'm not doing any incisal overlap, which means I do not do any finish lines when I do veneer preparations in lingual or in palatal side. In this case, when you do finish line in lingual and in palatal side, so ceramic may be really thin, and if you need to make any adjustments, you may get thin enough and make a compromise. Occlusal compromise. Okay? My technical support say there was some technical problem. So again, butt joint, no occlusal, no incisal overlap, nothing from palatal side. Okay, this is important because In that cases, when you do overlap and you have a ceramic in palatal side, I mean the finish line and ceramic goes there as the piece, separate piece to the palatal side. There are a lot of elastic deformation on tooth itself. Even with proper occlusion, you may get cracks because of the elastic deformation. So butt joint is the golden standard nowadays. We talk about this more during our previous online masterclasses. So I do really recommend you to attend these online masterclasses. The recordings are available on our webpage. MZ, if we are just trying with first veneer and we don't have a lot of money to invest into everything, are there any budget-friendly tips you can mention? All these materials are costly and they add up. Look, hydrofluoric acid is must, silane is must, composite cement is must, phosphoric acid is must, adhesive is must. So normal good burrs for preparation must, hand pieces must. So where you want to save money? In sandblasting you can save money. You don't buy sandblasting right now, but then you will buy it later on. Okay, so just the rest that I mentioned, it's a must materials to bond your ceramics. So this is the thing. Okay, Jordan, if I'm pronouncing name correctly, the question is, I had a veneer case with a show out effect. You could see teeth under veneer shine through. There was enough space, so did technician wrong ceramic? How to avoid show out effect? Thank you very much. Yeah, we were discussing this show out effect. If you gave enough space to your dental technician, which means before doing case, you discussed with your dental technician color change or color issues, and then your dental technician guided you regarding space or thickness of ceramic restoration that he has to have in order to change the color. And then you start preparing teeth considering that thickness. If you followed all the principles of preparation, controlling yourself by depth marking burrs with a silicone indexes, and you sure that you gave enough space to your dental technician, and during try-in you have this show-out effect, this is problem from dental lab. Dental lab in this case has to redo veneers by their own cost. But if your dental technician guided you regarding the thickness of ceramics and you prepped but you didn't give your dental technician enough space, this is your fault. So in this case, when you have show out effect, again you have to send these veneers back to dental lab and redo them, but on your own cost, unfortunately. So you have to follow instructions of dental technician regarding the thickness that they need to have, and during preparation you have to get a really good culture of prep control with depth cutters, with mock-ups, with the silicone indexes. This is really important, and then you will have less problems with these show-out effects. Ayman, can we do ceramic veneers in edge-to-edge occlusion? Actually, we can if this occlusion is stable, no chipping on patient's teeth, and you are not making veneers just longer. So in just the color changing cases, you can. So there is not strict contraindication. Okay, Ahmed, do you recommend the trend of direct composite injectable veneers? My friend, this is an online masterclass about bonding protocols of ceramic veneers. I don't do injectable composite veneers, honestly speaking. MZ, I love that you answer all our questions so helpfully and patently with many details. It's really nice, shows you care. Yeah, really, thank you very much. Because, you know, all your questions, all your feedbacks are really important for us. Because everything we do it for you. And because of your requests, because of your demand, because of your passion of dentistry, we also grow. To be able to present to you interesting information, we have to grow as well. So it's like an exchanging of experiences and energy in dentistry. So thank you very much. Also, I like that you have very honest, impartial product recommendation, no advertisers. Actually, I do not belong to any company. And believe me, there are many companies that try to convince me to work with them, to promote their products. And I say to them, there is no best product in the market. Many products are similar. So there will be no advertisement. If you want, I'm speaking to companies. If you want to work with me, just okay, I'm okay with this. If you'll support us during courses, for example, but I would not really directly advertise your product. I will show that in this case, maybe I'll use this. It's good, but there are some alternatives. So people have to know also alternatives. This is the thing. I'm not commercial speaker. I'm independent. Okay, Shakina, what is your view on prepless veneers or so-called lumineers? Look, lumineers is the commercial name, but prepless veneers can be done without lumineers. Just normal veneer can be also non-prep. There are some cases, really, there are some cases when you can do prepless, when you have enough space. You can do prepless. So forget about lumineers. You can do prepless veneers, normal ones, feldspathic veneers or Emax veneers or lace veneers done in your dental lab. They can do these prepless things. But personally, what I think about prepless veneers, the problem with them is that in the area of transition to the sound to structures in cervical area, if there will be no finish line, you may get some overhang or over contour. So personally, I prefer to do in cases where I have enough space and I don't need actually to prep, I do just finish line, okay? I just do finish line and it helps my dental technician to understand where to finish and where to start veneer. And for me also, I will get really good emergent profile, good position of the veneer, the control procedure, let's say, ability to control process of cementation, etc., etc., etc. So I do prefer to do some finish lines. Milan, I'm sandblasting with 15 microns. Is that bad? And my sandblaster has no water. I have aluminum oxide everywhere. How to avoid that? Yes, Milan, this is the problem with the sandblasters without water, because I worked actually with that type of sandblasters recently, and I had the same problem that aluminum oxide was really everywhere. Then I invested, I got some money, I earned some money and bought a sandblaster with water. So my recommendation is to go for a sandblaster with water. Regarding 50 microns, for some really thin enamel areas, it's pretty big diameter, because you can actually chip your enamel with that particles, but honestly speaking, there is no that significant difference between this 27 microns and 50 microns. 27 is less aggressive, let's say, less aggressive. This is the thing. Okay, Ruta, do you give any special regime for your patient at day one with veneers? Maybe what to be careful or to avoid staining drinks, food, etc. So basically, there is no special regime after cementation. The patient can eat everything, drink everything. The only thing is that I say to my patients that they have to be really careful in terms of their hard food, because I know that some people they like to grind with their teeth some bones, or some croissants that are really hard. So in this case, I say that you can break your own teeth with this hard food. So just be careful with your new smile. Be careful, be gentle, and this smile will last for many, many years. Lika says, thank you, Sir. Thank you also, Lika. I think that we actually answered all questions that were here. A lot of questions. I think there was nice discussion. I hope that I gave you enough answers. Okay, there is another one from MZ. Some people say heated flowable composite make the layer too thick and too rigid to bond veneers. What do you think of that? It's not, you didn't get it, not heated flowable composite, okay? Some people use to bond veneers or crowns with heated packable composite, normal paste composite. In this case, you may compromise fit definitely because it's difficult. It's a rigid composite. So I do not recommend to use this rigid, let's say, composite, even if it is heated. But flowable composite, highly filled flowable composite, you don't need to heat it. It's flowable. You can use this flowable composite, highly filled flowable composite, to bond your veneers in easy way. So don't worry regarding the thick layer with a highly flowable composite. This is not the same as normal packable heated composite. It is not the same. Another question, I cannot read the name. It is in Arabic. Even though I try to read from right to left, still I cannot. Is the type of veneer prep affect the cementation? The type of the design of preparation may affect fit of your veneer if you prep very badly or you do a lot of undercuts, sharp angles, etc. But cementation procedure is the same. The protocol is the same. Elias, the question from this guy: what is the longest lifetime of veneer you know, and what did you notice changes about those cases like gingival recession, etc.? I can say from my experience, I have follow-up about 10-11 years, but I know some dentists that I learned from with follow-ups 25-30 years. Imagine that. And regarding recession in that term, just imagine yourself. I see your face. You are pretty nice-looking young guy. But imagine yourself in 30 years, if there will be a changes or not. There will be changes definitely, and you may get some recession because of the age. So, unfortunately, we are not getting younger. We are getting older, and our skin and our gum also. So, in that case, you may change veneers. By the way, but I know pretty few dentists with that huge, tremendous clinical follow-ups of porcelain veneers, even when dentin adhesives were not on the market. Imagine that. Do you gingivectomy by yourself or do you transfer? How long you wait after gingivectomy with veneers? It depends. Gingivectomy or crown lengthening. If I need just to do a gingivectomy, which is inside sulcus, I can do myself. If I need to do crown lengthening, I refer. And in this case, for crown lengthening, we wait 5-6 months. What is the lumineers? Yeah, man, please Google lumineers. But believe me, it's not the real dentistry that you need to follow. Just Google it to understand what is lumineer. But for real dentistry, for clinical based dentistry, you don't need it. Okay, so my friends, was really happy to communicate with you, to answer all of your questions. Keep in touch. Next month we will have a really good another online masterclass with the same environment, with the same strategies, with the same way of education, with the same way of presentation. No theory, just demonstration over shoulder procedures. There will be veneer preparation strategies for posterior teeth, molars and premolars. I really wish you a pleasant stay in your home. If you are still in evening time, enjoy, get energy for tomorrow working day, and I wish you not to have any debonding. I wish you not to have any postoperative sensitivity. I wish you longevity of your porcelain veneers. I wish you confidence, and I wish you, my friends, all the best, and may the force be with you. Keep in touch. My name is Maxim Belgrad, and see you next time. Bye.